Good day, dear friends. Thank you very much for inviting me here, for being here. I'd like to talk about how we reevaluate the meaning of different TKIs during pregnancy in female patients today. In fact, our patients live long lives, as it was already said, and family planning is a very important issue now. The data of new registries appear, and moreover, we know that when we are talking about patients' leukemia and pregnancy, the medical and ethical dilemma is we meet medical and ethical dilemma both. We do not know, can we treat them or can we stop treating? It was already proved that under well-defined circumstances, an optimal treatment in pregnancy is feasible in many diseases that require chemotherapy. And the chemotherapy leads to increased rate of birth abnormalities only when it is used in first trimester, and when chemotherapy was induced after 12th to 14th week of pregnancy, the rate of birth abnormalities was from 3 to 5%. That is comparable to general population. The effect of new targeted therapies is still not clear, and of course we try to avoid them in pregnancy and state they should not be advised. However, the emerging data may change our view for some of new TKIs. Talking about pregnancy, we should notice that crucial periods of prenatal development will influence on our decision whether to treat or not to treat. The first obstetrician weeks until week 5 really are not susceptible for teratogenesis, because if something happens with the embryo, some toxic effect is observed, it will end in death of embryo and spontaneous abortion. The principle, everything or nothing. The most thrilling period is major organogenesis from week 6 to 10, when all events may occur, including major congenital abnormalities in case of any toxic exposure. And after week 10 till week 14, the placental barrier is being established, and after this, fetal period comes. Here we can consider risk benefits of the treatment for the patient. Only functional defects or minor abnormality can be observed. And this fact is proved by the publication that is now that was published more than 10 years ago. The abnormalities on Imatinib were observed mostly in patients who received Imatinib in first pregnancy trimester. Moreover, those patients received other teratogenic drugs, including hydroxyurea, warfarin. And moreover, some of the birth defects that are frequently observed in populations, such as hypospadias with a frequency 1 per 180 boys, was also accounted to Imatinib here, and omphalos and exomphalos as well. So we will never know whether all these effects indeed related to Imatinib use, or was there any effect of combined toxicities, combined events. As regards the TKI of second generation, nilotinib has shown no teratogenicity in preclinical trials, and we till now have very limited data of its use during pregnancy, but a very low very low level of birth congenital abnormalities. As regards dasatinib, in contrast, it showed a lot of harm upon to fetus. Malformations were found. Hydrops fetalis was described in patients when it was used in both in early and late pregnancy. This drug has a high placental transfer, and Imatinib and nilotinib have low placental transfer. Less is known for bosutinib because only few cases were described. They were summarized at ASH last year. So the best patient to be observed in the best female patients is during pregnancy is a woman who has achieved a sustained deep molecular response, and we can promise her that she can stop the drug safely, be monitored without any interventions. But the real life gives us a lot of unplanned pregnancies on different TKIs with a variety of treatment response status. And the other situation is chronic myeloid leukemia diagnosed during pregnancy, what to do. Here are some cases from our center that and what decisions we made for these patients. Female onset in pregnancy in a young woman, 20 years old, her first pregnancy, desirable and planned. Increased blood count was seen in first trimester with a slight left shift in formula to myelocytes. And in second trimester, her blood count was white blood count was 86,000, and also thrombocytosis was observed. Together with the other changes in blood formula, it all led to refer the patient to local hematologist, and chronic myeloid leukemia was approved. The patient was advised to refer to the central clinic, but she couldn't come. The local doctors had no experience of treating female during pregnancy, and they asked our recommendation for pregnancy termination and started treatment. Considering the second trimester of pregnancy, we found no reasons to terminate it, and we knew that they had no other options, interferon or leukapheresis in the local clinic. We advised to start Imatinib generic from 27th week of pregnancy, together with other concomitant therapy. A rapid hematologic response was, of course, achieved within 4 weeks. Then the patient received Imatinib for 4 years. Her level of residual disease was fine, and even she was observed later within a treatment-free observation trial, Ruski, for 2.5 years, so she is treatment-free now. There was a spontaneous delivery. A healthy boy was born, and he is now 6 years old. They visited our clinic just a month ago. The second case deals with pregnancy on treatment. This was the patient, 27 years old, at diagnosis. We had no initial data for the risk score, but we knew that she received hydroxyurea for 1 year and then Imatinib for 3 years. And these red columns represent her cytogenetic response. We see that she didn't achieve any, she didn't receive complete cytogenetic response, and she was transferred to Nilotinib, 800 milligrams, and got major molecular response. Then she got pregnant. Nilotinib was discontinued since week 4, and the pregnancy was first desirable. The patient was 34 years old. She wanted to keep it. So the starting point was major molecular response, and nearly 8 weeks later, we observed a very rapid and a very high increase of BCR-ABL. We didn't even believe. We repeated this test, and again very high level of BCR-ABL was observed, and we decided how to treat her further. We discussed the options with the patients, remembering that she is resistant to Imatinib, considering interferon, but knowing that we probably could not achieve a good response here, and this patient was already at 20th week of pregnancy, and we started Nilotinib 400 milligrams one day. She had a decrease of BCR-ABL till the end of pregnancy, and later she restarted Nilotinib in full dose after delivery and got, at long last, a deep molecular response. The pregnancy outcome was spontaneous delivery. We measured the concentration of Nilotinib in umbilical cord blood, and it was twice less than in maternal blood. So we have seen that placenta worked, and halfly stopped the transfer of the drug to the baby. Here a healthy boy was born. Now he is 4 years old already, developing normally. In the last case, the pregnancy on treatment in a patient age 32 with a high initial SOCAL score. She was resistant to Imatinib, no cytogenetic response, and transferred to Nilotinib. She got a complete cytogenetic response, additional chromosome abnormalities and Phe-negative cells, but she got a deep molecular response and got pregnant. She stopped Nilotinib at week 5 of pregnancy. This patient had already got a child, but this pregnancy was highly desirable because it was second marriage, and she had been treated for infertility for several years before. She was 36 years old already. Here we substituted Nilotinib for interferon, and we could see that the BCR level was high on interferon. The lowest level that could be achieved was 2.6%. However, the patient restored her initial response, a deep molecular response, within 2 years when she returned to Nilotinib 800 milligrams. There were several adverse events on the interferon during pregnancy. First was the flu-like syndrome, which was expected during the first 2 weeks. And the second was rather severe anemia. And we could not increase the dose of interferon to achieve better effect. She received only 3 million two times a week, and she received ferron drug supplies, but the level of hemoglobin increased only after she stopped interferon and returned to Nilotinib. The outcome was normal. A healthy girl was born there. Generally, talking about the data that have been accumulated at present moment, we may refer now to the largest collection of pregnancies, the pregnancy registry supported by ELN. The data were first presented at EHA this year. The rate of birth abnormalities was 1.7%, and they were not life-threatening. The relationship to TKI use was considered unlikely by physicians. We got to know that that 70% of patients took TKI when they got pregnant and stopped them early. We also saw that more than 50 patients used Imatinib or Nilotinib in late pregnancy. Among them were also patients in whom the drug was administered for the whole pregnancy. Here there was also our contributions for the patients who took Imatinib or Nilotinib in late pregnancy, knowing that they have a limited placental transfer. The update of this data will be shown to you by Elisabetta Bruseza on Sunday, December 8th. And you may see the new data about pregnancy management in these patients and the updated collection of ELN pregnancy registry. As regards the Russian experience, it is rather big now. We have more than 100 patients and 128 pregnancies which ended in delivery. And we also see that the majority of patients stopped TKI during first trimester, which had no harmful consequences. Generally, we use the scheme that considers the term of pregnancy and leukemic burden, and according to it we analyze the patient individually, thinking how to treat her in first trimester and how to treat her in late pregnancy. We may observe without TKIs, with any TKI till week 15th, and consider Imatinib or Nilotinib to benefit for the mother in late pregnancy. At any gestational age, we do not use any other TKIs, do not use Dasatinib, and we may continue interferon if a complete hematologic response is preserved and at least MR2 remains. So I would like to conclude that the management of female during pregnancy needs flexibility in the real life setting, and the risks of mother and baby should be considered. The initial molecular response and term of pregnancy may define the treatment choice. Thank you for your attention.